Please welcome our next speaker. Our next speaker, I'll tell you a little bit about him, but I have to be honest, I had a chance to chat with him before lunch out in the hallway, and the first thing I'll say before I tell you all this great stuff is he is an incredibly nice human being who honestly cares about those around him, and I picked that up in 5 minutes of conversation. I think you'll see how amazing his heart is when he begins to speak to you as well. He started his journey, he is born to the child of two immigrants from Taiwan who were hardworking people. And their relentless commitment to sacrifice and service, it just glued itself to him, and it was passed down to him in his life. He was raised in Indiana, has those traditional Midwestern values of humility, honesty, integrity, and obviously the golden rule, do unto others. He was a valedictorian in high school, went on to Cornell University, and after med school, he became the chief resident at Tufts University in Boston. While he was there, he won the Meade Johnson Award for outstanding scholastic performance in family medicine. He began practicing in Massachusetts in 2003, using both primary settings as well as functional medicine in his practice. And he began specifically going after chronic illnesses, trying to find those root causes of things like Lyme disease and mycotoxic illness. He also founded the Personal Care Physicians Group in 2014. He is a current president of ISEAI. He has a relentless drive to find root causes, and he is driven by the ability to empower his patients with choices and honor in their treatment. His goal, as he works with all the different organizations and groups around him, can be boiled down to one phrase as he works to scale root medicine in order to make patients better faster. And he's going to tell you all about it today. Ladies and gentlemen, welcome Dr. Mark Suh.
Okay. Good afternoon. Everybody all right? Thanks first to Vibrant America. It's my privilege and honor to be here. I know it takes a lot of work to put these kind of events on, so especially those of you who may not get as much credit and FaceTime. Thanks to everybody who's put in so much work to make this happen. Respect and honor to the other colleagues, the presenters this weekend. I'm again just really privileged to be here in this panel of folks. And then absolutely for those here, practitioners and those online, big time honor and light to you as those who are fulfilling missional service. I know that those who are here are a different breed of practitioners than, no shade, it's just you're a different breed. So thank you for your dedication and your service to your patients and your clients who you see. Those who know me well, especially in my office setting, but my family too, they know that I don't use the word excited very often, but I was excited to be asked to participate in this conference. I'm even more excited now because much of what we're going to talk about today has already been kind of connected in. It's going to connect together many pieces of what you've already heard today from the excellent previous talks. So it just makes it smooth, kind of flow together even smoother, and in a lot of ways kind of makes my job easier. Feels like a lot of it's already been validated. So we're going to, let's just get going. Green button here. All right. Longevity redefined. The intersect of toxicity and longevity from inflammation to invigoration. Here's our outline for today. We're going to talk a little bit more about just aging. What is it? And then a little reverse order there. How do we measure it? What is happening biologically? Can we identify causes? And of course, what can we do to reverse it? So, to define anti-aging or longevity, obviously, we must need to first clearly define aging. What do we think of when we say aging? Most of us, historically at least, think about chronological age. But the definition, the paradigm is shifted into biologic aging. Dr. Hyman's already spoken to this quite a bit already, so we won't go into great detail, but the bottom line is chronologic age is a time-dependent variable. Biologic age is not time dependent. It's a measure of our biologic health in regards to measurements we're going to talk about in a minute. But the chronological age and biologic age do not have to correlate, and they often don't. At birth, in younger years, our biologic and chronological age are more apt to be proportionate and correlate. But as time marches forward, that biologic aging, or especially the aging rate, may be accelerated, decelerated, or some of us might be along a more predictable trajectory of quote-unquote normal aging. A key is that the accelerated or decelerated aging process or rate may vary from time to time. It's not a fixed rate. And the effects on aging are multiple and very much environmentally related, as has already been discussed several times today, very meaningfully by Dr. Peters just in the last hour. Here's one of those iffy statements I was going to put out, but I don't have to do that anymore because Dr. Hyman's already spoken to it. In the research world, certainly, aging is being looked at now as a disease, and as such, a global crisis. Statistically, as such, aging is the greatest risk factor for the majority of chronic diseases. Now, when I first came across that, I don't know how many people here would agree with me, but I'm kind of like, duh, it just doesn't mean a lot for me, okay? And I'll give you further insight that when I say that, I was saying that to my wife, because my wife is I will dare brag that she is a world leader in metabolomic research, which is a lot of how I think about clinical medicine and a lot of what is in the meat of today's talk. But nonetheless, she talks about this and I'm saying, this is like the research thing where you guys say stuff that just doesn't have a lot of application. I'm not sure where that's going. But here's the key. Delaying the data now is suggesting that delaying the rate of aging by 7 years can cut the incidence of chronic disease in half, and that if biological aging can be slowed by 20%, the US can save $3 trillion in the next 50 years. And we all know that money talks, and so now that research has meaningful implications, with more to come, no doubt. Okay, so how do we measure it? Well, we're not going to talk about this in length. Don't worry, Dr. Glenn's going to speak about that next session, so we're not going to step over lines here. But ultimately, the question is, what's the most objective measure of biological age, especially in the research world anyway, all right? I'm just going to say, for me, trying to understand this stuff, and so I've had a lot of conversations around this stuff, especially with my wife and others, but historically, a lot of the biologic clock testing, which is some of what Dr. Hyman already has alluded to and referenced in some of his slides, it's largely been based on epigenetic markers and methodology. And what is now evolving is a movement towards metabolomic markers and methodology, all right? Furthermore, we want to just make a quick comment here, as Dr. Hyman has also already spoke about before lunch, that it's not just a matter of our snapshot of our current biologic age with these biologic clocks, but also the rate of aging. And here, faster is not better. We don't want to be the hare, we want to be the tortoise. The little graph depiction was actually in Dr. Hyman's slide of his own testing. This is the Dunedin pace score on the rate of aging. That is the let's say the Forte Premier rate of aging test being used at this time. So I've alluded to epigenetic testing and metabolomic testing. So let me just make a quick comment here on metabolomes or metabolomics. So by definition, the metabolome is this measure or knowledge base of all small molecules in blood. Again, for me, I'm okay, what does that mean? Well, more pragmatically, the far, far, far majority of diagnostic tests that we have available to us as clinicians, that we use every day, that we look at results with every day, that we're even tested on of ourselves as patients every day, are metabolomic biomarkers, metabolites. Now, the world of metabolomics has very meaningfully put a lot of attention into the topic of aging and longevity now, and as depicted here as a selection of such findings. This paper from Panyard and colleagues in 2022, they highlight a number of individual biomarkers, metabolite markers, and the groupings of those metabolites into various categories reflective of findings that are correlate with accelerated or decelerated aging. Some of these, again, we won't go into details about these, but some of them will resonate with you and some of them might be slightly mildly surprising. So as we think about what's emerging now, what I see as emerging in the metabolomic world is this, yeah, some of the data is helpful for characterizing the snapshot biologic age, but more importantly for me is what's emerging in the metabolomic world in regards to the findings and correlation with rate of aging as well as suggested causes of aging. All right, so here's an example, and again, Dr. Peters just referenced his last talk, so again, a lot of connections here. PFAS, forever chemicals. The sources are plentiful, right? There's plentiful sources as to where they come from, but this is being meaningfully captured in metabolomic research as an age accelerator, as an environmental exposure. So if we look at this sort of pictorial of what can be pro-inflammatory, pro-aging, or anti-inflammatory, anti-aging, as we look at these categories of environmental exposure, so we've got forever chemicals, PFAS, missing an S there. So these are pro-inflammatory, pro-aging. How do they actually lead, how do the forever chemicals lead to aging or inflammation? They do so through methylation as an epigenetic domain, if you will, a vehicle or mechanism of epigenetics. As Dr. Peters already said several times in the last talk, environment affects the genes. And I'll just extend that by saying through epigenetics, through methylation dominantly. Vasant mentioned this morning the comment about I'm blanking on here, sorry. He mentioned the comment about the effects of the metabolites or the environment on methylation and the methylation affecting the DNA. Oh, he mentioned methylation as well as histone modification, sorry. And that is a further emerging area of epigenetics. But so far to date, methylation, which we all are familiar with in general, is the heavy dominance of research and where the attention has been paid to date. But let's go further. Besides PFAS and forever chemicals, so you've got healthy microbiome, no surprise, all right? Anti-aging, anti-inflammatory. Again, Dr. Peters spoke to that quite a bit last hour. Going forward, all right, cigarette smoking, nicotine, again, not surprising, pro-inflammatory, pro-aging. Healthy endogenous steroids, again, further validation extending from Dr. Peters' talk. Anti-inflammatory, anti-aging, as are healthy fats. A little bit more granular now. A metabolite being found out, VMA. Many of us may recognize this if you think about it from organic acid testing. A metabolite of norepinephrine and epinephrine, perhaps suggestive of chronic stress, which has been spoken about both at the end of Dr. Harmon's talk and Dr. Peters' talk about the impact of sympathetic, neurosympathetic fight or flight, okay? On the flip side, serotonin, a meaningfully robust finding these days in the metabolomic world as a anti-aging correlation. And then lastly, just for a select set of markers and topics on this slide today, DMT, it's actually missing a letter here. This is a metabolite that is essentially the equivalent of like a low GFR. And so it's just reflective that kidney function is a meaningful impact on aging. And so in totality, what's emerging with the metabolomic world is being able to identify, characterize, profile the exposome. So again, I didn't know it would happen, but fantastic. Dr. Hyman's already introduced that term for, I'm assuming most, if not all of us already know that term, but the knowledge and base, the study of all things as exposures, environmental exposures. Okay, so now we've talked about the definitions of aging between chronologic aging and biologic aging. We've talked just a little bit about measurements of biologic age specifically. And so now we've already hinted at, but we're going to extend further. Biologically, what is actually happening when we age, i.e. what are the metabolomic and epigenomic testing reflecting on a biologic level? So just a little bit more here, okay? Just fleshing out just a little bit more. So here, and I give this all credit all due to my wife, and she gives this illustration all the time in her talks. And we're going to talk about great-grandma's banana bread recipe. Award-winning, delicious banana bread, all right, and from years and years ago. That recipe has been passed down to multiple lineages within the family. Now there are 4 different family lineages scattered throughout the US making great-grandma's banana bread. But they don't taste the same. And none of them taste as good as great-grandma's recipe. Why is that? Well, we can think about the instructions, the recipe itself, as genetics, the programming, the wiring, the coding, the directions, and the execution or the translation of those genetics as the epigenetics, the actual execution of it, the making of the product, all right, on a simple level. So what has happened over time? Why do these 4 families and their children and their sub-family units, why do their banana breads not taste the same as great-grandma's? Well, at least in the day and age before scanning and mass photocopying, et cetera, right? So a paper recipe is handed down to son and daughter. Maybe the recipe got a little smudged with a little water, maybe a little bit of the, while making the banana bread itself, maybe some of it became a little bit less legible. Maybe a family couldn't get an ingredient one year, they substitute with something and thought, doesn't really taste much different, we'll just kind of keep doing what we're doing the following year. Maybe another family says, we couldn't get that brand of whatever, we're gonna substitute with this, and it's not quite the same, but let's just try it out, and doesn't taste that different, so let's just keep up that, and so on and so forth, and so now the recipe has been altered. The epigenome has been altered with aging. Essentially, the recipe becomes less legible. It becomes sometimes perhaps even unreadable in some areas. So this is what is actually happening on the foundational level in the DNA. The bottom line is that methylation changes cause aging, and that's what the epigenetics have been about, DNA methylation. The coding does not necessarily change, as Dr. Hyman's already spoken about. The translation and the processing of that coding has altered. You can see that the little methylation attachment points to the DNA at age 20, they just don't stay consistent over time. Something changes with that epigenetic profile, okay? And so now let's move from, we've talked about biologic versus chronological aging. We've talked about the different ways to measure and emerging ways of measuring biologic aging. And then we've talked about biologically what those tests reflect in regards to what's actually happening biologically and even at the DNA level. And so now, can we identify causes of aging? And this is where I'm going to allude back into what is emerging in the metabolomic research world. So here I'm going to just kind of zoom us out just for a second and talk about aging in like 2 different aspects as a paradigm. So increased inflammation, or in the context of the aging world, longevity, we can talk about the term inflammaging. I'm assuming the far majority of us, if not all of us, know that term as well. And then we can talk about decreased resiliency or decreased ability to regulate that inflammation, whether due to a weaker immune system, reduced hormones, again, apropos to Dr. Peters' talk, and more. And so just as a validation point, I guess, these authors from 2018, they're rather well published in multiple papers. So they define in this paper, one of many, inflammaging. During aging, chronic low-grade inflammation, called inflammaging, develops and contributes to the pathogenesis of age-related diseases, and I'll extend that to say aging period, all right? And they propose there are 3 categories of stimulators of inflammation or inflammaging. 1, non-self, i.e. environmental exposures. They list here just before that non-self circular, the pathogens, so bugs. I'll liberally extend that to say bugs and toxins, biologic toxins and synthetic toxicants, okay? So environmental exposures as a whole. Number 2, the self. They talk about endogenous cell debris, misplaced molecules. Essentially, we're talking about the senescent cells, Again, Dr. Hyman spoke about that a bit earlier, and there's going to be a whole talk on that tomorrow. So again, we're not going to get into that today here. And then the third category, quasi-self, which they talk about as the gut microbiota. For me personally, I think of that as the first points of contact between the self and the non-self, right? The first points of contact, the skin, the respiratory system, and the gut. And the gut, of course, being arguably the biggest one, certainly, literally a galaxy full of bacteria alone in the colon, by many estimates. We better hope we can regulate that well, all right? It's a static, constant, invariable point of contact with our environment, if you will. So in essence, when we think through all the previous slides all kind of put together really, and this again has been touched on already by more than one of the presenters already this morning, we're back to the discussion about nature versus nurture, genetics versus epigenetics. In fact, one of the key messages that came out of the Human Genome Project is that we're not that different across the world as a human species. We're not that different. It's not where the key is when it comes to chronic illness or solving disease, or now in this case talking about longevity and anti-aging. The key is the epigenetics. I think Dr. Hyman's slide was mentioning like 90% of effect is in the epigenetics, not the genome, right? And there's a lot of hope there because what you were wired with can be modified for in upregulation, downregulation, et cetera, okay? So nature versus nurture, genetics versus epigenetics, the effects of the environment, i.e. epigenetics, i.e. environmental exposures, the effects on the self. And that's what we're going to focus on for the rest of this discussion today. So highlighted here, or maybe reflected, illustrated, by just a podcast from just a couple months ago by the Mayo Clinic, how a lifetime of exposures impacts health, the Exposome Explained. And I love that title because I say this to patients in my office all the time. I'm a full-time, 100% clinician, basically every day of the week, weekends, as needed kind of thing. But it's a lifetime. I just say, look, the longer we live, the more we are reservoirs of bugs and toxins. I mean, patients, I don't like to use the medical terms exposome, okay? So I say bugs and toxins. The longer we live, the more we are harboring as a reservoir bugs and toxins. And it's just a fact of life. It's not to be a Debbie Downer. It's not to be a glass half empty. It's factual, right? In fact, it's not even all bad. I mean, we need a lot of that microbiome, as, again, Dr. Peters went into a lot of that with the gut health. So this isn't all bad, but regulating it and having resiliency is the key. A lot of that, again, several people have talked about that Goldilocks principle, right? Not too much, not too little, being able to reestablish homeostasis and balance. So what we're, again, what we're going to focus in on for the rest of this chat is that aspect of epigenetics where we're talking about toxicity as our environmental exposures, i.e. we're not going to talk about, and I'm a big proponent of, again, same discussion about the limbic system, trauma, whether big trauma, little trauma, how we've behaviorally, mentally, emotionally responded to different life circumstances, whether of our, more of our own decision and actions and such or not. We're going to leave that to the side, but that is a whole nother talk that I think warrants great emphasis. And I actually love that arena, but that's not for today. All right, we're going to talk about toxicity. So in that regard, I ask you, when it comes to toxicity, what comes to your mind, right? When I say toxicity, these are some things that more often come to my mind that I think I'm not alone with. It might be hazardous waste chemicals, it might be mycotoxins, it might be heavy metals, other biohazardous chemicals. But today I'm going to ask us to broaden our definition. Let's see if this slide got changed a little bit. Let me just see if no, it's already in there. Okay, so I'm going to ask us to sort of redefine toxicity to be exposome, right? Almost like, can we redefine our talk from the intersect of toxicity and longevity to be intersect of our exposome and longevity, and defining toxicity as the entire environmental exposures, AKA our exposome. And I even say to sometimes I even say to patients, this can even include food. Now, I don't think of food as toxic. I hope nobody else does either. I mean, some people have real food exposure reactions and all that stuff. So, but nonetheless, I think the way I think about toxicity or the exposome are really anything that does not derive from me, from the self, that can lead to reactivity can lead to inflammation. It might not, it might be neutral, it might actually be positive as an environment, but it does not come from me, all right? So now we're going to basically do a brief survey looking at a variety of paper literature studies reflecting this impact of our environmental exposures on the self, on chronic inflammation and inflammaging, all right? So let's just jump right into it. So the left half slide, the World Health Organization's website talks about mycotoxins as adverse health effects of mycotoxins which can cause acute poisoning, but can also lead to long-term effects such as immune deficiency and even cancer. I mean, this is the WHO's website. You look at this other paper on the right, apropos to, again, this conference, mycotoxins and senescent cells impacting oxidative stress, hypoxia, and immunosuppression. So for me, that's really important because, again, with aging, we're talking about becoming, living longer, having more and more bugs and toxin exposome exposures and becoming more and more reservoirs of such, but also a reduction in our immune system, hormones, et cetera, whether secondary to that mounting exposome profile or independently. I don't know that I personally have a great sense of that yet, but nonetheless, immune suppression, we certainly don't want a decreased immune system. I think that can be agreed upon. All right, furthering the topic about mold-related illness, mold and mycotoxins here, this paper 7 years ago discussing the cause-effect of, or correlation, if not cause-effect, of such on CIDP, chronic inflammatory demyelinating polyneuropathy. Now, so the name just says it all, right? Chronic inflammation. And chronic inflammation, inflammaging, aging. Extending the topic on fungus and fungal toxins. So now we're going to be moving into Candida as yeast. So this paper, these authors are pointing out that Candida in colonization, not even infection, all right? I'm presuming probably overgrowth, like greater than typical colonization, but nonetheless, Candida yeast gut colonization leading to systemic inflammation, as measured in this paper in the form of joint inflammation arthritis. This paper, these authors talk about, extend that thought further, delineating a specific pathway by which Candida leads to systemic inflammation, IL-17. And we'll come across that pathway actually several times in the subsequent slides here. But somewhere in the middle of that paragraph, the top third of the paragraph, the acknowledgement that IL-17, Candida, has impact on dermatitis, psoriasis, chronic dermatitis, psoriasis, inflammatory bowel disease, arthritis, multiple sclerosis, i.e. chronic inflammation, and again, I submit to you chronic inflammation, i.e. inflammaging, when we're talking about the aging world, i.e. aging. Lastly, here, a quarter of a century ago, the Mayo Clinic researchers, some Mayo Clinic researchers point out, we've found the cause of most chronic sinus infections in immune system response to fungus, not bacteria. So I think the highlight point topic here was not so much about, it was more about fungus versus bacteria, but this is a quarter century ago. And again, chronic sinusitis, a form of chronic inflammation, inflammaging, aging. Moving away from thinking about root causes in our environmental exposures in the form of mold, yeast, mycotoxins, i.e. fungal toxins, and now just thinking about age-related illnesses, age-related diseases as a reflection of aging, all right? Segueing from what we just started with on the left, Candida albicans again, and this paper, I believe, it was just a few months ago, June 2024, accelerating heart disease through a specific pathway of factor II alpha signaling. We can move to the right. Smoking, again, no one's going to argue this. Smoking, yeah, we all know there's a correlation with lung cancer, but not only that, certainly also heart disease, stroke, and type 2 diabetes. Okay, not shocking, okay, but just pointing it out. And then moving from that synthetic toxicant, if you will, to another synthetic toxicant led as a survey or reflective, what am I trying to say? Representative of heavy metals, all right? There's many heavy metals we could talk about, but just wanted to highlight this one, lead exposure and its effects on cardiovascular disease. Shifting from heart disease, if you will, to hyperglycemia and diabetes. So these authors point out that low-grade inflammation, the second little highlight section, low-grade inflammation translates into hyperglycemia and even hyperlipidemia. Yes, if you read just above that second highlighted portion, overnutrition is a major factor with inflammation here, but not the only. What other sources of inflammation, low level, less low level, moderate level, high level, might lead to hyperglycemia and diabetes? Well, these researchers in 2019 from University of Kentucky take that a little bit further even and point out, we're challenging the notion that the high sugar itself is what actually leads to diabetes. We're suggesting that the mitochondrial damage, mitochondrial impact is what leads to diabetes, and the high sugar being essentially effectively the result of such. And as such, that the bottom right, the very last sentence, shattering the prevailing assumption that glucose was the culprit of diabetes, i.e., again, let's consider root cause, at least in some cases. I don't know that they really got into that. More so, their focus was, again, back into Th17 as a pathway. Extending it a little bit further beyond just hyperglycemia and diabetes, staying in just age-related illnesses, here, this paper, they're talking about the independent risk of chronic inflammation as defined by patients who have systemic autoimmune disorders, systemic vasculitis, severe psoriasis, ulcerative colitis, and others, and that these folks have a greater risk of cardiovascular disease and type 2 diabetes independent of other typical factors, and that, as the very last sentence is highlighted, clinical management of these patients of their chronic inflammatory disorders should seek to reduce cardiovascular risk. Chronic inflammation, age-related diseases. Age-related diseases, chronic inflammation, inflammaging, aging. All right, so let's turn back around from age-related diseases back into sort of more pinpoint root causes. So we started out talking about mold and even a little bit of candida, for yeast or mold mycotoxins, and then yeast. And here we'll get back to, say, other pathogens, all right? So while the CDC may not be willing to, while they're only acknowledging the correlation here between various pathogens and chronic symptoms, pretty confident we would all agree in this room that it's more than just symptoms. There are many, many, many patients, don't know a percentage, who they have ongoing persistence of these pathogens in their body, all right, in their bodies, as reflected by this paper, again, just a few months ago, May 2024, findings of Borrelia burgdorferi, Lyme disease, demonstrated to infect and enhance invasive properties of breast cancer cells. Pivoting one more lane here and making further connection to previous slides and previous talking points in this segment. So can we link the dots between environmental exposures, effects on metabolites that are now being emerging as a identification in metabolomic testing and research, and the effects of those metabolites and those root causes on epigenetics, i.e. methylation, leading to DNA effects and aging? This first paper in the top left from 8 years ago is referencing DNA methylation as a vehicle between environmental chemical exposures and autism spectrum disorders. Bottom left, a little bit broader of an article talking about DNA methylation in a variety of human diseases. And then even when we shift from the environmental exposures over to the self category, from the non-self to the self category, this other third paper from 12 years ago, a dozen years ago, talking about DNA methylation perhaps being a vehicle, a mechanism for metabolic, hormonal, and immunologic changes in postmenopausal women, i.e. chronologically anyway, in an aging process, right? I've had this interesting question I've posed to my wife saying, so yeah, for me, how do I know how much of these self topics, hormones, immune system, et cetera, how much of those are sort of programmed, if you will, predisposed natural degeneration versus secondary to exposome effects? To be determined. Don't know. Yeah, there's definitely question in the research world in that regard, but at least as a dozen years ago, they're already talking about methylation changes as a vehicle one way or the other. And then one last, the circle's got, that's all right. One last table here. This is a sort of raw data table, so sorry you can't read the bottom that well, from the omic age testing, which is, Dr. Glenn may disagree, we'll see, but I think arguably the most the robust biologic clock test, or panel, I should say, at this point. But if you look at the far right at the bottom, these are all foods. All right, this table is just completely about food. So again, we're going from like pathogens, biologic toxins like mycotoxins to synthetic toxicants, and then now we're talking about just foods as a specific focus. The bottom right you'll see, and I love it because so Dr. Hyman validated my own personal thing about cereals too, right? The higher the scores here, the coefficients on the graph, 0 being the middle, the higher, the more pro-aging and accelerated aging, and the more negative, the more anti-aging, anti-inflammatory. If you look at the bottom right, the most, the grouping categorically with a decent jump at the end there, highly processed foods. Second highest, cereals. Third is sweetened food and beverages. And then if you go all the way to the left side, you got the fishes, all right? And then you'll see, if you move over about 4 or 5 over from there, you'll see healthy fats, oils, nuts and seeds. Yeah, alcohol, slightly just a little bit on the right side as a grouping there. Alcoholic beverages, beer, wine. So yeah, Dr. Berry this morning talking about, there's probably some small percentage of us here who never drink alcohol, but yeah, we were sitting at dinner last night and having just a little something, and all right, so a little bit pro-aging, but not as bad as cereals. All right, so Vibrant didn't ask me to put this in here, so just disclosure, but I thought, hey, it's worth a while, because if we ask the question, well, how do we characterize these environmental exposures, right? These bugs and toxins, expose them on a more macro level anyway with patient care at this point. And so these are tests I use on a regular basis. So Vibrant's got a lot of panels here. So tick-borne panel, I'm assuming most of us are familiar with this, maybe all of us, so don't mean to be redundant, but we've got the tick-borne panel. We've got the PFAS panel. There's this total tox burden panel that can be broken down into the panels within them if you want to sort of a la carte it. But you got the mycotoxin panel, you've got the heavy metals, and then oops, one slide got taken out. So all right, there's one more, the environmental toxins, which include the BPA and phthalates and atrazine, triglycine, and many, many, many more. Looks like we might have, let me see. Oh, a little bit out of order. Okay, sorry, one slide just got, sorry about that. All right, so there's the mycotoxin panel, the heavy metal panel. Here's the environmental toxin panel. And so, let me think, was there another slide there? No, let's just move on. So yeah, I'm looking at a lot of those things in those panels and those tests in a lot of patients. If someone were to ask me, well, do you look at all of them in everybody? I won't get into that. That's, it's how do we deliver patient care might vary from practitioner to practitioner, practice to practice. And for me, a lot of it is very dependent on what the patient is asking of me. What are they here for? How motivated are they? What is their resource budgeting, for cost of testing, et cetera? How far are they really willing to take this? Are they wanting to just sort of get validation for what they're reading about online and hearing in podcasts and such? Or are they really wanting to take action, right? How far do they want to take it? So let's move into, the final segment here, like what can we do about this stuff? Can we reverse it? And so, let me see, there's that one slide. Essentially, I'm gonna backtrack, I apologize. So in the epigenetic world, the question becomes back to great grandma Smith's banana bread recipe. Can we make the epigenome rereadable, or can we repair the epigenome? And I'm guessing that a bunch of slides maybe just a little bit out of order. Oh, there it is again. Okay, so there. So can we make that recipe, can we fill in the blanks? Can all the king's men and all the king's horses put Humpty Dumpty back together again, right? Well, in the end, David Sinclair's work, Dr. Hyman referenced him earlier as well, published in Cell Journal in 2023, that using epigenetic interventions, they were able to accelerate or decelerate aging in mice. And maybe in the end, just commenting, hey, it's a paradigm shift in how we think about aging, which Dr. Hammond's already done a great job talking about on a broader view. So there's a lot of work right now on the epigenetic level talking about treatment discoveries that are certainly rapidly evolving. But for now, we certainly can take action Monday or continue taking action we've been doing all along to treat toxicity. And again, I submit to you, not just hazardous chemicals, and not to pick on Pittsburgh, but it was in the news recently they're talking about the Parkinson's belt, so I just that just comes to my mind, but showing all these industrial smoke pillars and buildings and such like that. It's not just that, all right? It's the bugs, it's the indoor mycotoxins that many of us are exposed to, many times unknowingly, et cetera. There's a lot, even foods, okay? A lot of that goes back into foods, which we have a lot of control over, for better or for worse, as I tell my patients, because if you have control over it, then you have to confront and own whether you're going to be responsible to take action on it or not. And I'm not being a hypocrite there, because I got my issues too. But nonetheless, we have actionable points on treating toxicity right here and now. And so I submit to you, the bottom line is treating toxicity is longevity medicine. And I think that the talks all throughout this morning, I feel like I've put a lot of attention into referencing Dr. Hyman, Dr. Peters' talks, but Dr. Berry, very, very much so. He was like a slew of info. I was a little bit, that was a lot, but there's a lot of good stuff, right? I got to catch up with him again. I don't know if you're in here right now, because I've been looking for you all morning, but I couldn't find you. But man, like his talk about this all day long, right? The herpes comment, right? HHV6. I mean, we hear, I don't know, it feels to me like we come across some news release about HHV6 in the news, in research being correlated with dementia is like every, 5 years or something like that. I'm like, okay, well, we're just revalidating something we've already known many times over. But yeah, treating toxicity is longevity medicine. So in summary, the problem, when we talk about the intersect of toxicity and longevity, from inflammation to invigoration, I submit to you the problem being that chronic toxicity or environmental exposures leads to inflammaging as a natural process, if you will, a quote-unquote natural process. It's the nature of the beast. We are broken people living in a broken world. This was not meant to be a forever thing, okay? We will age, but there are ways to reduce that aging, and we have hope and we have ways to reduce that process and lead a better quality of life, all right, if we're motivated to do so. The solution is treating toxicity, anti-inflammation, and longevity. Sort of again in summary, so today we've kind of honed in on environmental exposures being just one category of toxicity, again, not speaking so much to psychological toxicity, mental emotional health toxicity, traumas, the adverse childhood events topic that was brought up earlier, all those pieces, all the life stresses that even Dr. Jess talked about just in the last year for her. We all go through this, right? I mean, none of us here are immune or protected from life, right? Life stress, life crap, stuff happens. A lot of it's not our fault, but it's our problem. We're not immune to that. That's another story. But these toxicity triggers, both individually and collectively, whether these bugs and toxins or other life circumstances collectively lead to chronic inflammation. And if we think about that within the bug and toxin world, I ask us to think about pathogens broadly, viruses, fungus, parasites, bacteria, and there's many, many subtypes of all four of those categories and then some, all right? And then when we think about toxins, I think about them split up into biologic toxins and synthetic toxicants. And with that, I'll make a quick little plug, maybe shameless plug for, I'm privileged to be on the board with, Mike mentioned ISEAI, the International Society for Environmentally Acquired Illness. And so if you go to that website and you go under the second tab where it says Get Help, you'll find this page pop up, and on the left side, the top few 5, I think it is, top 5 links are free links with downloadable information specifically to do with indoor environmental toxicity, specifically in the form of like mold-related illness, mold, mycotoxins, et cetera. They've been really, really well received, not just by the 450 or so members in our organization, but the public and even other practitioners who aren't members at large. So really, really good free stuff. A lot of fantastic work that the indoor environmental professionals, which are about 75 of the 450 or so folks, have put a lot of hard work into. I mean, I think we all know how difficult it is for humans in general to come to agreement about things. Then you think about healthcare professionals to come to agreement about things, and it's another couple levels more difficult. This committee is, it's been amazing how much synergy and how much, just work and dedication they put into putting together these documents. So I just want to kind of put it out there. And as well, ISEAI has its annual conference in a couple of weeks. It's virtual, it's completely virtual. It's just a Friday, Saturday, and it's focusing specifically on, this year, more specifically on indoor environmental exposure toxins, with a little bit of, little plug on EMFs, and then a little piece on biologic versus synthetic toxicants and toxicants from Lynn Patrick, for many of us know her, I think, in this room. That being said, I'll draw to a close. Thanks for, again, thanks for everybody for your attention, and especially thank you to U.S. practitioners for your ongoing missional service to your patients. Oh, I apologize, I do need to say this, so I do need to say that. So when we talk about from inflammation to invigoration, right, I think on a paradigm level, a principle level for me, if you're a practitioner who you're seeing people, or you're wanting to see people, as you know, in context of this conference on longevity and anti-aging, if you're working with people who are generally doing all right, symptomatically anyway, and they're looking to optimize wellness, right? Does this conversation pertain to those patients who don't have symptoms? I submit to you it does. Now, you're going to have a conversation with them as to how far they're willing to take it, right? Because if somebody says, I don't remember ever having a tick bite, I don't have joint pains, I read that people with Lyme disease have joint pains, I've never had a bullseye rash, why would I want to go test for Lyme disease? Or if you test for it, like, how's I got all these markers and I don't have symptoms, right? That's a conversation that you've got to be ready to have, much less if you're going to take it beyond, just the one panel into multiple panels, all right? What do you mean I got all these phthalates and whatever else? Like, I feel pretty good, right? So that's the point of care conversation that is more of a dynamic and a challenge. On the flip side, if you're a practitioner who's working with sick patients, right, especially the chronic complex patients, who some of them are like on the door of disability, does this information, this discussion today, does it pertain to you also? Because we're talking about longevity. How many of those people who are chronic complex and chronically inflamed sick people are thinking about longevity and anti-aging? They're just thinking about, how can I get out of bed tomorrow? How can I have less pain? Much less, I don't have any bandwidth to talk about longevity, but I submit to you that it is one and the same. That when we are treating people with chronic inflammation for these underlying exposome problems, one way or the other, whether symptomatic or not, or regardless of where they're at in the spectrum of symptomatology, severe symptomatology, to little to no symptomatology, it is the same spectrum. But it is that conversation that is the art of medicine that I find fascinating, but also very challenging, because we all know it can vary as to how much time it takes to have that conversation with that one person in front of you, okay? And they're all different people with different kind of mindsets, certainly. But it is one and the same. And it's not easy for me to get my head wrapped around per se, but I don't remember if it was one of the talks, the first 2 talks this morning, or if it was, somebody this morning was talking about, a risk factor, I think it was Vincent talking about risk factor-based approach versus symptom-based approach. And I would submit that I've come to terms recognizing for myself, they're not one and they don't have to equal. And some patients are able and apt to take action on a risk factor-based approach even when they don't feel it. For me, commonly they're the real diggers. they're listening to podcasts, they're researching stuff all the time, they're coming to me and challenging me with, am I keeping up with blah, 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 versus those who are really symptomatic and don't even think that they're in the boat to talk about anti-aging and longevity. But I still nowadays have that same conversation with them, and I bring in and say, hey, look, you may not feel like it, but when we've moved from this target to that target to that target in addressing your exposome profile, we're not only just addressing inflammation, we are actually, as a positive piece of encouragement to them, that we're also moving in this anti-aging longevity world. You can also participate in this movement and awareness of anti-aging and longevity. So with that, thank you very much. I'll close.